Good morning, everyone. Welcome to the Lynn Cancer Institute updates. We're keeping you in the know in 2024. We're very grateful to have you all with us today to learn from our very esteemed panel of physicians, 8 physicians today, so we are very, very fortunate. Our physicians will be educating on their individual specialties, all relative to breast cancer. October is National Breast Cancer Awareness Month. We all love to wear pink, but it's also a reminder to educate ourselves and, if appropriate, to schedule your annual mammogram. We are so proud to introduce you to and recognize our amazing team who all specialize in breast cancer treatment. At the Lynn Cancer Institute, we believe that education, prevention techniques, screening and early detection, treatment options, and the expertise of our staff and our latest technology will truly save lives. During this presentation, your Zoom will be muted, and in the interest of time, each physician's bio was sent to you by email. We invite you during the presentations to please take notes, and at the end of each specialty presentation, there will be an opportunity for question and answers. So that being said, we're very proud to welcome you to the Lynn Cancer Institute and introduce you to our very own medical director of the Lynn Cancer Institute, Dr. Louise Morell. Thank you, Doctor.
Thanks, Jan, and thank you for organizing it. Thank you for my teammates and their participation in this event that we all love to do too, because we get to pick the topics that we think are both cutting edge, but also of great interest to our patients. And it really gives us a little dabble of what it means to look at all the multidisciplinary advances in breast cancer, and also to introduce you to some of our new specialists. So I'm going to attempt to share my screen. My topic today is going to be concise, because each of these, of course, could be their own topic, and we want everybody to get their opportunity to speak today. But I've just chosen to basically look at some of the updates in DNA and try to clarify, when you're hearing about DNA testing, what does this mean, or what are these different tests? And I am going to use brand names, if you will, because a lot of them are being marketed as brand names. And for clarity's sake, I apologize, because it's probably not the scientifically appropriate way to do it, but you're going to hear about these tests because of their names. So I hope you'll permit me to do that and talk about them. So the 3 things I'm going to touch on today are a test that you may have heard of called Signatera, another test that comes out of a lab called Gallery, and that is also known as GRAIL. And then I'm going to speak a little bit about genetic testing for inherited genes, because, of course, that is something we've been doing for a long time and critically important. And just to remind everybody in a very brief way, because I have to have a couple diagrams here, we are looking at the fact that cancer always has a problem that is starting in the DNA inside of the cell. So we have a cell, you all remember the nucleus, inside there is the DNA. The DNA basically decides everything. It gets turned on, it gets turned off, and it makes proteins through that process. But essentially, every cancer is going to have DNA problem, because the DNA is running the cell, and if it's running amok, if it's doing the wrong thing, if it's growing, then there's something going wrong with the DNA. And that's why there's a lot of attention onto that. And one of the differences in the things that you're going to see in a moment is illustrated in this, is that basically it has now become possible not only to extract DNA and study whatever segments that you want through basically next generation technology that can look at millions of particles at the same time, but here's what's going on in some of these newer tests. So the blue here illustrates the normal cells, and there's DNA in there. And then the yellow or orange at the bottom represents a cancer or a growing cancer cell. And what it's trying to illustrate is that these cells are breaking down. So that's what these words over here mean: necrosis, apoptosis. That means cells are breaking down. And as a result, the fragments, the cytoplasm, the things that were inside those cells are getting into the circulation. And so they're going to have fragments of DNA in the circulation. And this is what has changed with some of these new tests, is the ability to look for abnormal fragments of DNA in the circulation and ask the question, does that give us a clue as to what might be going on outside of there, where there might be cells growing as a tumor? So each of these tests, we're going to ask the question, where is the DNA being studied? We're going to ask the question, what is the test designed to detect? And then what is the utility of the test? So let me spend 2 minutes on utility, because this is where the medical responsibility is on our part. Is the test useful? A test is useful only if it gives us information that somehow prompts an intervention that results in an improved health outcome. That is the measure that we have to say, if we're going to give you advice, do this test, is to ask ultimate question is, does it help anything? Or is it just going to raise a lot of questions? And then, of course, we can do it as an investigational process, which is where a lot of these things are right now. But we want to be very careful, because we have studied every other thing that we've done for its actual usefulness. If we now have 100 tests, but none of them are useful, then we're just going to really confuse the issue. So some of these things, really, that's the key cornerstone question that remains to be answered. All right, so let me start with Signatera. Signatera is a cancer circulating DNA test. It's unique because what's done is that the tumor, the original cancer, gets submitted. Remember, I just told you that all cancers have DNA abnormalities. And so that the lab will take the tissue, will look for DNA fragments, and they'll make up a signature, if you will, for that tumor, for that malignancy. And they'll say, okay, now that individual person has a panel. This means they're not going to be mapping every bit of DNA, but they're going to pick out 12 to 16 different spots that they know in that particular person's tumor were abnormal, and use it as a way to try to mark what's going on. This is the same pictures I showed you before, but basically the test compares the segment of DNA to a normal segment of DNA. So the way you know it's different is you take that person's normal tissue, they take that person's cancer tissue, and you find out that there's differences, and then you test for it. And you basically are doing it by collecting blood or plasma, because they'll take the plasma off the blood, and the cancer tissue and normal tissue. And you're basically looking for very specific things, so you're not mapping the entire genome. So here's the summary of it. This is newly approved technique. You're testing those circulating fragments of DNA that are in the bloodstream. And it has proven to be useful in some scenarios now, in colorectal cancer and in GU cancer such as bladder. That is a very narrow group where this has proved to be reliable, predictive, and have some utility. It is not being used in any other cancer that we can say with the same kind of reliability that it's useful. It's very limited and really, I would say, experimental for any use in breast. It might be used in breast to see if the cancer is shrinking to pre-op chemotherapy, but we usually don't have trouble figuring that out. The tumor is there, we measure it, it shrinks down, and that's going to be a more meaningful test anyway. It certainly is not a screening test to find out if the person has cancer. It could be something that could predict that a cancer is going to recur because there's molecular signs of it, but it's not reliable. So we would not want to create an environment where we're acting on something that we think we can find a molecular marker, but it hasn't yet proven to be useful. And I think one of the things that when you read studies about this, and I've looked at some of these studies where people get excited, is that you see that the studies, the number of people that this has been done on and has shown to be beneficial is very, very small. So I think that what everybody would say is this whole new idea that we might be able to use DNA specific to the tumor as a marker is interesting, has been shown to be useful in certain cancers, has not yet been proven in breast cancer, and every meeting I've been to, everything I've read suggests that is not a standard of care and not really something that's going to help you, because finding that piece of DNA in there doesn't tell us anything. It doesn't tell us that you should start worrying. It doesn't tell us that you're going to die. It doesn't tell us things like that. Now, it doesn't mean it's never going to be useful. It's just very early, and the number of patients that are in these trials have been sometimes they're in the 20 patients or 25 patients, and we're talking about 200,000 patients a year with new breast cancer. So we need the data to be more mature. You're going to hear that in the next thing as well. Okay, so the next test that this is a drawing not too useful, but basically the next test comes from the second, which is a totally different concept. It's called GRAIL, and some of you may have heard of it. And this is a process, this actually shows you how they went looking for it. They basically took patients with cancer and without cancer, and they tried all kinds of measurements that they could make to see if anything would show up in the DNA that would be helpful. And they did not find that the test that I just showed you was the answer. What they found is that when cancers are formed, not only is the DNA abnormal, but certain things are turned on or off through a method called methylation. And so they found that they could look at patterns of methylation and they could potentially determine that this person could have cancer. And they have rushed to put this out into market to say, hey, we can do a test. We can do this test of your blood and we can detect patterns of methylation. And those patterns of methylation might suggest that you have a cancer. Here's the thing. Most of the publications are in people who have an obvious cancer. So a mammogram detected breast cancer, a PSA detected prostate cancer, a chest x-ray detected lung cancer, something that is already we know the person has. And very little data exists in the setting where the person has nothing going on. All of those tests are normal. And now we try to see, oh, is there something going on? The findings that they report are about 5 out of 100 patients who do this test, this blood test for methylation, have a positive result. And half the time they find something. But the something isn't necessarily useful to find. So you end up with half the people who have a positive test very nervous because they can't figure out why. And the other half of the people who have a positive test may or may not have something that is helpful to find it out early because it might not have been a problem for 20 more years, or it might not have been a problem at any time in their lifetime. So this is also very, very premature. And I was speaking to a patient this week who was a very nervous patient who had taken this test. And I said, here's the bottom line. You're taking this test because you feel you are going to be less nervous if it's negative. But if it's positive, and we can't find anything, and we go through thousands and thousands of dollars of tests, you're going to be devastated. And we don't even know that this is helping you yet. So it's a very premature test. It's available. It costs about $950 through self-pay, but then there's a lot of other tests that have to be done when there's a finding. So the good news about this is there's a lot of big population studies. So like the study, that the presentation I went to, they were showing some positive results from using GRAIL and detecting cancers, but it was studies of about 35 people. This is not thousands of people. So the studies now are involving 150,000, 300,000. And so we're going to have more information on the usefulness. So basically, this is a test from the blood. It is designed to try to detect if that person might have any of those, any cancers, many of which finding it in a DNA fragment is not helpful. It's looking not at DNA mutations, but at methylations or turning on and off. It can't tell you what cancer you have. It can tell you maybe it's more likely to be part of the gastroenterology group or part of the urinary group or part of the GYN group, but it's only a suggestion and it's not narrowing it down yet. So, and then the problem is really finding things early or not early. You're going to have false positives that you can't find anything. So the utility is not proven yet, and that's why it is in the self-pay category. I think that as we work with these groups and we get to saying if you're in a high risk group and you're looking at specific cancers like pancreas or ovary that are so hard to find, is where we're ultimately going to land with this test. And the final test, which since I only have 2 more minutes, is going to be on the cancer genetics, which you're pretty familiar with. But the point of this is testing normal cells. Usually we use a white cell, either from saliva or blood. We're looking at the DNA and we're mapping many, many cancer genes. They're not all of equal potency, but we can do that through the DNA of the normal side cells. This is well described to be beneficial in breast, ovarian, colon, uterine, pancreas, prostate, and some other rare conditions when you have multiple cancers. And people who are tested before 2016 and then get retested with this novel kind of pattern testing that can look at hundreds of genes, or I like to do about a 36 cancer gene panel, have about a 6% chance. So if you've been tested before, and of course, this is unlike any of the other tests, it has implications for both the patient and the family. This is just two little illustrations of the genes that we are looking for. So the blue on the right is showing you if you have colorectal cancer gene and you compare that to the patient who doesn't have it, general population, that's the difference in the risk of colon cancer. And so there's actions we can take. And similarly with BRCA, the difference in the risk of ovarian cancer goes from less than 2% to 40%, from breast can go up to 80%. So these are very, very impactful genes that give us an opportunity, but we have guidelines for every single one of these that get updated on what we should do to reduce the risk. And I wanted to put one last illustration up here, even though I know I'm going kind of fast at this point. There's a lot of genes now in these panels, and these are some of the examples of genes that might show up in your panel. When you look at this, what this other color bar is showing us is that this is what a family history does to your lifetime risk of breast cancer, about a 20% or twofold risk of breast cancer. Most of the other genes are not impacting that even as much as family history. So even though it's helpful to sometimes find them and we can go through what that means, the fact is that there's only a handful of genes, and BRCA1 and BRCA2 were way too high, though we didn't put them on there. There's about 6 or 7 genes that have a big impact on breast cancer, or enough of an impact to say we should do something different. But the rest of them look like a family history, so it's informative, but it's not going to change things very much. So our conclusion is germline testing for inherited genes is beneficial, it's useful, it can alter survival, screening, treatment, and prevention. And it's been proven. We have many, many studies that show the utility of this testing, and it affects family members as well as the person. It does need careful interpretation because we can have variants and other kinds of findings that aren't actionable and don't have the big impact. And I think even if the individual is not going to be affected because of the family effect, there may be times when we should do it. Signatera is currently investigational in terms of breast, but there are trials going on. And Gallery or Grail, which is a screen to see if the person might have some kind of cancer somewhere, is probably premature. It's self-pay. It's going to lead to a fair number of false positives that makes it not too reassuring. So I'm waiting for the data to come out before I'm advising patients to take that test. And that's my conclusion.
Thank you, Dr. Morell. I don't see any questions in the chat box, probably because we're all going to need a few minutes to digest that. But that's very amazing information, and we're very grateful for all your research. Thank you. Our next speaker will be Dr. Juliette Tay, diagnostic radiologist, and her topic will be on breast arterial calcifications. Dr. Tay?
Hi, everyone. I'm Dr. Tay. Let me share my screen. Hi, everyone. Today, my topic, I'm Juliette Tay. I'm from the Department of Radiology. And today I'm not going to talk about something that's technically cancer related. I'm going to talk about breast arterial calcifications, which is showing to be an opportunity to modify cardiovascular risk factors. I gave this talk in 2019, but because of its continued relevance, I'm going to give it again and update with the latest research. I was also asked to give this topic by someone who had a personal experience with it, so I think it's relevant to definitely members in the community. So this is the outline for my talk. We'll talk a little bit about statistics on breast cancer and cardiovascular disease. We'll talk about what are breast arterial calcifications and who is most prone to developing them. And we'll talk about why they're significant and how to report them, or why we should report them, and what to do if you as a patient have breast arterial calcifications on the mammogram. And here's a slide from the American Cancer Society that talks about how many people are projected to be diagnosed with breast cancer in 2024 and what the breast cancer mortality is, expected mortality. So it is expected that there's going to be about 370,000 total breast cancer cases. 56,000 are DCIS and 310,000 will be invasive cancer. And the breast cancer mortality is projected to be 42,000 patients. Now, breast cancer does not spare any ethnicity, as you can see. All the races that are impacted by breast cancer, white Americans, African Americans, Native Americans, Hispanic, and Asian Americans as well. So I'm going to take this opportunity to pivot from the pink ribbon to the red ribbon to talk about cardiovascular disease. And cardiovascular disease is actually the #1 cause of female deaths per year, and it claims the lives of over 400,000 people per year. And so this is about the same number as women who are diagnosed with breast cancer, and is 10 times greater than the amount of women who are dying from breast cancer every year. And it's important to remember that cardiovascular disease is largely preventable. 75% of coronary heart disease can be prevented by lifestyle choices such as smoking cessation, exercise, and a healthy diet. So it's important to know if you have it or not. And more than half of the US adults don't know that heart disease is a leading cause of death, despite being the leading cause of death for the past 100 years. So what are breast arterial calcifications? We'll go back and talk about where we find them, and we normally see breast arterial calcifications on a screening mammogram. The American College of Radiology recommends screening mammogram of average risk women starting at 40 and continuing annually. And according to the JACR in 2017, this results in about 39 million mammograms performed every year. And it's about, for women greater than 50, about 70% of women in the United States get screening mammograms. And if you're part of a managed care program, that increases to 88% of women in a managed care program will get screening mammograms. However, it's important to remember that there is no routine screening for coronary artery disease. So what are breast arterial calcifications? These are breast arterial calcifications are calcifications within the arteries of the breast, and they're easily detected on the mammogram. They have a very distinct look. It's a two parallel dense lines, or what we call tram track appearance, and this is different from the regular calcifications, benign appearing calcifications in the breast, or even the malignant appearing calcifications of ductal carcinoma in situ. And we've seen these for years, ever since we started doing mammograms, and largely up until recently has been considered to be an incidental finding or something that's non-actionable. Sometimes for many years, we don't even describe them. How prevalent are they? In about 10 to 50% of all women have breast arterial calcifications. In women in the ages in their 40s, that's about 10%, but increases to about 50% in women in their 80s. They're also associated with increasing pregnancies, diabetes, chronic renal disease, but there's no association with hypertension, obesity, and smoking. So what are how calcifications form? If you look on the right side of your screen, this is a histological picture of a breast artery, a cross section, and you can see that there's calcifications, the dark purple, in the middle layer of the artery, or what we call the tunica media. There are 3 layers of the artery. The tunica intima is the inner layer, the media is the middle layer, and that's where the calcifications form in the breast arteries. Now, this is very different from coronary artery calcifications, or arteries in your heart. Those calcifications are located in the tunica intima, which is the inner layer of your of the coronary artery, within an area of lipid deposition, plaque formation, plaque rupture, luminal stenosis, and then sometimes there's an area of calcification. And so why are breast arterial calcifications on the mammogram significant when for years we never even talked about them? Well, they are significant because of three associations. Number one, cardiovascular disease, and even more specifically, atherosclerotic cardiovascular disease, and also coronary artery calcification. So let's explain those. Cardiovascular disease is any disease of the heart, blood vessels, myocardial infarction, stroke, valvular, aortic valve disease, or cardiac valve disease, pulmonary embolism, or peripheral vascular disease. And more specifically, atherosclerotic disease is the disease of the plaque buildup within the coronary arteries, and this narrows the channel within the artery, restricting blood flow and can cause myocardial infarction or stroke. And here on the left, again, is the histological example of the luminal narrowing associated with repeated plaque buildup, rupture, and luminal stenosis. So there's a very numerous studies have shown a very strong relationship between breast arterial calcification and cardiovascular disease, global cardiovascular disease. And a lot of these earlier studies were smaller studies, case control, cross-sectional, but most recently in 2023, there was a large prospective 5,000 patient study of a very diverse population of women, which also showed a positive hazard ratio with the association of breast arterial calcification and coronary artery disease. Coronary artery calcifications are calcifications related to a coronary artery, as like we talked about earlier. And breast arterial calcifications is also related directly to coronary artery disease. In this prospective study of over 5,000 patients, also another positive hazard ratio associating breast arterial calcifications with coronary artery disease. And this one, the NUDI study, increased risk of developing stroke and coronary artery disease after 10 years of follow-up. So in the primary care or in your doctor's office, there is a way to predict what your first atherosclerotic event will be in 10 years. And this is the pooled cohort equation, and it asks several questions related to age, sex, race, blood pressure, cholesterol, history of diabetes, smoker, and what treatment you're on for hypertension, cholesterol, or aspirin. And based on the results of these questions, it puts you in a risk category. So what coronary artery calcifications can do is they can further risk stratify. So these people who have less than a 5% risk of a 10-year event, they don't need to be placed on a statins given that if they have high cholesterol. But if these patients over 20% should be on the statins, but these in-between people, if they do have coronary artery calcifications, they can consider statin therapy. So it is having coronary artery calcifications is an important risk stratifier. The problem is not everyone undergoes a cardiac CT, so not everyone knows that they have coronary artery calcifications, but we know that many people do undergo mammograms. 39 million people undergo mammograms every year. Approximately 70% of those over 50 will have a mammogram. And if there's a correlation between breast arterial calcification and coronary artery calcification, then this could be extremely helpful in managing heart disease. And so given the significant overlap in postmenopausal women and those undergoing screening mammography, the reporting of breast arterial calcifications on mammogram has the potential to identify women at higher risks of cardiovascular events. So let's talk about reporting them. Some people are concerned about reporting them on the mammogram, that this might cause undue patient anxiety. It might increase the burden, administrative work on referring physician, and it may lead to over-imaging. Some women say that they wouldn't want to do anything if they knew they had breast arterial calcifications, but they might want to confirm this with a CT cardiac score to confirm coronary artery calcifications. But we did a study in 2018, and a large percent of women, 96%, preferred to know what their breast arterial calcifications were, especially if they did or didn't know if they had any coronary artery disease. They all, most 95% would like to know what their status is. So we report them this way, and it varies. Not a lot of radiologists all over the United States report them. But what we say is the decision to further investigate the implications of breast arterial calcification should be made after discussion with the referring physician. In Canada, they're a lot more specific. They say there's a strong association between breast arterial calcifications and coronary artery disease in multiple studies. Consider correlation with your risk factors as clinically indicated. If you have breast arterial calcifications, I think the good starting point would be to talk to your referring physicians. They can do a quick risk assessment or have a conversation on cardiovascular risk factors. So I had the opportunity to talk about breast arterial calcifications. We talked about breast cancer. We talked about what the breast arterial calcifications are on the mammogram, and the people prone to developing those are women of older age, those with increased parity related also to diabetes and chronic renal disease. They're significant because of their association with cardiovascular disease and specifically coronary artery calcifications. So we report them here at the Women's Center. And if you have them, I think a good starting point is talking with your doctor about your risk factors and maybe some lifestyle modifications. Thank you.
Thank you, Dr. Tay. That was fabulous information, and we appreciate all your research on that. And our next speaker will be Dr. Carrie Ann McDonald. She's breast surgical oncologist, and her topic will be premenopausal breast cancer. Thank you, Dr. McDonald.
Thank you. Good morning. My name is Carrie Ann McDonald. I'm one of the breast surgeons here. Thank you for joining us. So I'm going to be talking about premenopausal breast cancer. All right. So it's not just a feeling. The feeling that there are more young women being diagnosed with breast cancer is in fact true. 20% of breast cancers occur in women still having regular periods, less than 10% in women 40 years of age, and less than 2% in women under the age of 35 years. Young women are more likely to develop breast cancer with more aggressive biological features compared to older women. So features which include larger tumor size, advanced tumor stage, negative hormone receptor status, so they tend to have more aggressive types of cancer, triple negative breast cancers, HER2 positive breast cancers, all kind of contributing to poor prognosis among young patients. And for this reason, young patients are treated with more aggressive therapies. All right. So the American Cancer Society released a new report this month that says that there has been a rise in breast cancer cases in young women. So this report showed an increase in 1%, a 1% increase every year since 2012, and a 1.4% increase in younger women every year since 2021. The report also showed differences among specific groups. So breast cancer rates among Asian women under the age of 50, there was a 50% increase in diagnosis since 2000. So they looked at 20 years of data. They had 200,000 women. They were looking at trends, and pretty much all racial groups had some kind of shift upward in breast cancer. And one interesting statistic from that report was that 2.51% annual increase in breast cancer rates for women who are between the ages of 20 to 29 years. So the increasing number of women, younger women suffering from breast cancer is becoming a public health concern. This is a video excerpt from Good Morning America, where they're looking at young women opening up about their emotional experience with breast cancer. And these women are saying, you're not too young for breast cancer. You're not too young for any cancer. I still have my whole life ahead of me, but so much time was taken from me. No symptoms, no family history. I felt fine. I was young. So this is a very difficult time for young patients. They're often at the peak of their careers. They have young children that they're caring for. They're finishing school, et cetera. So to kind of add on the stress of a breast cancer diagnosis can be very difficult. So why are young patients developing breast cancer? We know that there is an increased incidence of obesity in the United States. Higher BMI is associated with a higher stage. Changes in lifestyle, having children at later ages, not having children after 35 years of age, reduced activity, alcohol, reduced breastfeeding rates, hormonal exposures, environmental factors. So, it's very difficult to pinpoint. So given these increased rates, should screening start earlier? And, from 2009 until recently, the United States Preventative Services Task Force recommended that if you were a woman and you were average risk of developing breast cancer between the ages of 50 and 74 years, you should be getting a mammogram every other year. But clearly, the rates are going up in younger women. And more recently, they changed their guideline to say that you should start breast cancer screening at age 40 instead of waiting for the recommended age of 50, kind of finally catching up to what we as oncologists have been recommending for years. So women who are under the age of 40 do not typically undergo breast cancer screening unless they are high risk. So high risk because they have a gene mutation like BRCA, high risk because of family history. So there are a number of kind of predictive models that we can use to calculate one's risk of developing breast cancer. But if you're a woman, you're under 50, your risk is average, and you're not meeting kind of these high risk criteria, regular mammograms are typically not recommended because breast tissue at that stage is very dense, making that evaluation very difficult. There was a study that looked at over like 70,000 screening mammograms in average risk women who were under the age of 40. And the positive predictive value was only 1.3%. So that means if the mammogram is abnormal, the likelihood of it being cancer is only about 1%. So, you could argue you could be doing these excess procedures causing, physical, emotional discomfort for a very small likelihood of true disease. So when it comes to treatment, young women really do have very unique needs. And when we think about surgery, it can be hard to know what to do, mastectomy or lumpectomy. And in the young patient population, fear is, a very big driver sometimes of surgical decision making, and other types of decisions that are being made are driven by fear, not knowing what decision to make, not wanting to make the wrong decision, wanting to live for a long time. We often hear, I don't want to ever have to deal with this again. Risk of recurrence is also a theme that comes across in this population, wanting the surgery that's going to give me the best chances. And so, when we as oncologists think about surgery, we're saying things like, well, lumpectomy and mastectomy, the survival is the same. It's equivalent. Recurrence rates after breast conservation is 2% at 10 years. Mastectomy is not the more aggressive approach. Mastectomy does not eliminate the risk of a recurrence or even a new cancer. Some people choose to have mastectomy because of preconceived notions about radiation. So we talk about that. And some people even think that, if I do a mastectomy, I won't need the chemotherapy. And so it's really a lot of education. And, as a team, we're really trying to balance what do the statistics say? What does the research say with kind of the emotional aspect of dealing with this diagnosis? And it's all about a sense of well-being. It's body image, it's disruption in sexual life. It's all of these things which are really profound for this population. So in terms of medical treatment, young women again have unique needs. So most of them may need chemotherapy, and we know that damages their ovaries and can lead to early menopause and infertility. Women under the age of 35 who undergo chemotherapy have a lower risk of menopause, approximately 15%, compared to, for example, a 40-year-old woman who has a greater than 40% risk of menopause due to kind of the natural decline in ovarian function with age. Hair loss is a big concern, and especially bothersome in this population. So tamoxifen remains the standard of care in the adjuvant treatment of premenopausal women with ER-positive breast cancer. And 1 in 6 premenopausal women with invasive breast cancer is non-adherent to tamoxifen therapy. And this is because of postmenopausal side effects. They're not used to experiencing these things. Anti-estrogens can also contribute to infertility because young women are recommended not to get pregnant while taking these medications. When tamoxifen is prescribed for 5 to 10 years, a woman's ovarian function declines with time. And so she's not as fertile as she was at the beginning. any young patient with breast cancer, we always refer to a fertility specialist. But I mean, these are such hard decisions, and chronically tolerating something is much more difficult than kind of tolerating it in the short term. So like the more immediate the threat, we find that the more adherent patients are. So this is interesting because this came up for me once, young patients and kind of, having children after being treated. And pregnancy after a diagnosis of early breast cancer does not appear to increase the risk of relapse. And so there was a trial that essentially looked at temporary interruption of endocrine therapy to attempt pregnancy. And the result was that the 3-year incidence of breast cancer events was 8.9% in the people who interrupted the treatment compared to 9.2% in the control group. And so temporary interruption of endocrine therapy does not confer a greater short-term risk of breast cancer events. And so that's something we can share with patients, when they're thinking about family planning. And finally, I mean, we kind of already said this, but younger women, younger than 35 report more emotional distress, less energy than older survivors, even after years of treatment and kind of being diagnosed. And so it's distressing. And we have groups that are out there. This is the Young Survival Coalition. We have a premenopausal support group here at the Women's Center, because young patients want to see other young patients. They want to know what their experience is. They want to see that they've survived and are doing well. I mean, the typical, if you 30-year-old doesn't know people who have these chronic serious illnesses. And so it can be very dramatic. And if they're not partnered or they don't have very good social support, it's really challenging. And so the key things to remember as a young person is that cancer does not discriminate based on age. Know your family history, do your monthly self-breast exams, listen to your body, and really advocate for yourself. Young people don't always seek medical care, but obviously you know your body better than anyone else. And so if you feel something different from your baseline, you speak up. And that's it. Thank you.
Thank you, Dr. McDonald. Very, very important information. Our next speaker will be Dr. Hillary Shapiro-Wright, who will speak on, she's also a breast surgical oncologist, and she will speak on postmenopausal breast cancer. Thank you.
Hi, good morning. Thank you so much for joining us. So you just heard Dr. McDonald talk about premenopausal breast cancer, and I'm going to go to the other extreme and give a little bit of an update and some information related to postmenopausal breast cancer. So by definition, a woman is considered postmenopausal when they have not had a period for 1 year. It is the stage when a woman no longer has a period or ovulates, most commonly confirmed by laboratory studies as well. And the average age here in the United States is the early to mid 50s, but we definitely see variation from patients in their mid 40s up through late 50s as well. So, one of the questions that I always receive when I especially see older women who are in their 80s and 90s with breast cancer is, should I have stopped getting mammograms, or when do you stop getting mammograms? And there's a definitive recommendation, as Dr. McDonald talked about, when to start, but there really isn't any specific information related to when do you stop having mammograms. And commonly we do see women who are older age with breast cancers who have stopped having screening breast imaging and then present with a more advanced stage because it's palpable at the time they go back and have screening. So what I usually tell patients is, while there is no specific age, as long as a woman is in good overall health, and we don't look at comorbidity specifically like hypertension, diabetes, because those are still very functional diagnoses, that women should maintain getting breast screening. We usually use life expectancy of less than or equal to 5 years. You could stop. And I always tell women, if you're of an age where you decide you're not going to do anything if they find something, then you could potentially stop having screening. But for the general population, I do recommend continuing screening breast imaging. So about 2/3 of all breast cancers diagnosed are in postmenopausal women. It is usually diagnosed as a less advanced and less aggressive form than in the premenopausal, meaning that women are ER or PR positive, meaning hormone receptor therapy positive, that their tumors are influenced by estrogen and progesterone, and HER2 negative. Just as premenopausal women have risk factors, we look at age as the #1 risk factor after being female for breast cancer. The incidence increases about 1% per year for age. Late menopause after 55 is a risk factor due to the increased estrogen exposure. Obesity, especially with a higher BMI in a postmenopausal female, because the estrogen production in fatty tissue is their primary estrogen production. Use of hormone replacement therapy to manage menopausal symptoms, and alcohol use, increased alcohol use. We look at other contributing factors like family history, genetics, high-risk lesions, and history of chest wall radiation, the same as we do with a premenopausal woman, but specifically those others are influenced in postmenopausal women. So the big topic that we talk a lot about in postmenopausal women is hormone replacement therapy and its effect on breast cancer risk. Some studies show that as high as 40% of postmenopausal women will utilize hormone replacement therapy at some point during their perimenopausal or postmenopausal state to control these symptoms. Things like hot flashes, hair thinning, mood changes, and decreased libido are just a few of them. Most commonly, as I had stated, breast cancer in postmenopausal women is what we call estrogen receptor positive and progesterone receptor positive, meaning that the growth of the tumor is stimulated by estrogen and progesterone, whether it be the woman's own circulating estrogen made in the fatty cells or estrogen that's supplemented through replacement therapy. The body does not recognize the difference in the way estrogen is supplemented. So I wanted to review that because I very commonly hear women say, well, I was taking bioidentical hormones. That shouldn't have affected it. But whether it's pills, patches, creams, or pellets, the body just recognizes the hormone as it binds to those receptors. The increased duration of time used does increase risk, and risks related to hormone replacement therapy are greatest when you use combined estrogen and progesterone therapy. Over time, with discontinuation of the therapy, the risks do reverse themselves, and you have to look at the risks versus benefits. So we do know that there are some benefits to hormone replacement therapy related to bone health and cardiovascular health, and women should speak to their physicians in detail before using hormone replacement therapy to determine if it's something they want to use and how long they should be using it. I would never tell a patient not to use it, but we do recommend the lowest dosage for the shortest duration. So periodically reviewing how much you're taking and trying to wean off it over a period of time versus just long-standing use. And one other thing to mention is the hormone replacement therapy does increase breast density, and therefore mammograms can be harder to read and review. So breast cancers can be missed or not seen as effectively, I would say, due to the increased density in the breast. Women who are on hormone replacement therapy should consider ultrasound as well, in addition to mammograms for their screening. So treatments vary based on the disease process for breast cancer diagnosed patients. There are some systemic therapies that are designed specifically for postmenopausal women. So while tamoxifen for endocrine therapy is used in premenopausal women, aromatase inhibitors are used for postmenopausal women which affect the estrogen production from the fatty tissue. Women who are postmenopausal should discuss lumpectomy, mastectomy, and lymph node evaluation. Therapeutical surgical choices are based on the disease process, the breast size to tumor size ratio, and patient's genetics most commonly. One of the newer things in breast surgery in postmenopausal women is the safety of omission of lymph node biopsies in specific patient populations. So it's one of the newer things we're looking at and is being studied. There are some small short-term follow-up studies with about 5 years of data that look at women over 70 most commonly, with one looking at younger patients as well, that look at women who have good prognostic tumors. So estrogen and progesterone positive tumors, HER2 negative tumors, tumors that are less than 2 centimeters. And they're finding that it is safe in certain patient populations to omit the sentinel lymph node biopsy or lymph node evaluation, and therefore avoiding the risks that come with that. There is no survival benefit, as Dr. McDonald alluded to, when comparing lumpectomy with radiation to mastectomy. So again, it's usually a long discussion with patients and education to help patients decide the right choice for them. And you should look at the overall patient picture when deciding what surgery and procedures and treatments for postmenopausal breast cancer should be done. Thank you.
Thank you very much. That was very easy to follow your slides. Great information. We do have time for one question that was put on the chat box, and I don't know if the physicians can see it, who would like to answer it. I'll read the question and then one of you can respond. Wasn't there some talk of reducing the age for screening for African American women to age 30 due to the increased risk of more aggressive breast cancer? Dr.
Hi,
Tate?
I'll take this as a radiologist. So I think I do remember recommendations coming out similar to this, but I think it was more because of the increased risk for more aggressive cancer. African American women should know their risk for breast cancer, should talk to someone about what their actual risk is. And it wasn't that they should get screened with mammograms earlier. It was more that they should go talk to someone about what their overall breast cancer risk is, so that if they needed to screen earlier, they could.
Thanks. Thank you, Dr. Tate.
You're welcome.
Our next speaker will be Dr. Ivo Pastana, a plastic and reconstructive surgeon. His topic will be a brief overview of breast reconstruction options. And we welcome Dr. Pastana to our panel as our newest member. Thank you, Dr. Pastana.
Good afternoon. I'm going to start sharing. Again, good afternoon. I'm going to be speaking about breast reconstruction options. And I'd have to say that pretty much anything in breast reconstruction could be its own presentation. These are the important considerations regarding breast reconstruction, and a little bit about them to begin the talk is mastectomy. Mastectomy is critically important because that's where breast reconstruction begins. Timing of breast reconstruction, there are actually multiple timing options that may be used to optimize and meet a patient's goals. We're going to really focus on breast reconstruction techniques. And the final consideration is that breast reconstruction is itself a process. I wish there was a single step, but most commonly people will go through multiple steps to get to their reconstruction completion or to their goal. Briefly, the clinical indication for breast reconstruction is breast cancer surgery. Of the women that are diagnosed with breast cancer, 2/3 will undergo breast conservation surgery, and that is lumpectomy and radiation, and 1/3 of them will undergo mastectomy. Of the women who undergo breast conservation surgery, about 20 to 30% of patients will have a residual deformity that will require correction. And on the right side of the screen are images of what a lumpectomy deformity may appear like, as well as a mastectomy deformity. This is probably a take-home slide or concept. If we start thinking about breast malignancies and surgery for them, on the left side of the screen, you see lumpectomy. On the right side of the screen, you see mastectomy. And then we can begin to organize the options for breast reconstruction based upon the surgical intervention that was taken for the breast malignancy. Under lumpectomy, you see oncoplastic breast reconstruction. That is probably one of the most common forms of reconstruction that is done for lumpectomy deformities. On the other side, for mastectomy, there's implant-based breast reconstruction. There's tissue-based breast reconstruction. You see that there's an arrow between the two. Sometimes we do combine both implant-based and tissue-based reconstruction together. And then here in the upper corner under mastectomy is something called aesthetic flat closure. And we'll be talking briefly about each of these. Lumpectomy reconstruction. I'd mentioned oncoplastic breast surgery. And this is more of a mindset than any specific technique that is employed for reconstruction. And this mindset was first described by Dr. Odresch, who is a German breast surgeon who described this concept, which the breast surgeon approaches the cancer patient with aesthetic principles guiding the surgical approach to the breast. The most common technique that is commonly used in terms of oncoplastic breast reconstruction in treating a lumpectomy deformity is breast reduction technique. You can see on the left side of the screen, this is just an image depicting options for how to remove a tumor yet preserve and shape a breast. And on the right side, a patient who's actually undergone oncoplastic reconstruction with breast reduction technique. You can see she has symmetrical breasts at the completion with a more rejuvenated appearance to her breast. Similarly, another patient, you can see on the left breast, her lumpectomy scar from a biopsy, and she also had oncoplastic reconstruction with reduction technique. Importantly, we can perform the opposite side symmetry procedure during the same operation. That's why after their cancer removal, patient comes out with symmetrical breasts. I placed this picture into the oncoplastic reconstruction group because this is another common scenario that we see, a person who's had a central lumpectomy where the nipple has to be removed. They can go through similar techniques using oncoplastic reconstruction. And then once they're ready, if they choose to have nipple reconstruction, again, they will look like they've solely had a breast reduction rather than reconstruction following cancer removal. Mastectomy reconstruction. Implant-based breast reconstruction is the most common form of reconstruction, and there are 1-step and 2-stage techniques. This is an example of a person who's undergone both-sided or bilateral skin-sparing mastectomy. That's what SSM stands for. And immediate prepectoral 1-stage implant-based breast reconstruction. She had her mastectomy. She had her final breast implants, which were silicone gel in this case, placed at the time of her mastectomy. Another patient, this patient has had a bilateral nipple-sparing mastectomy with immediate prepectoral 1-stage implant-based breast reconstruction. Again, you see that her nipples have been preserved. Her scar is actually in the fold underneath the breast, which you really don't notice. This is a person who's had a left-sided mastectomy, immediate actually 2-stage prepectoral implant-based breast reconstruction. And on the opposite side, the right side, she had an augmentation of the breast with an implant as well as a lift. This person went on to have nipple reconstruction, but I have not included those photos just so that a person may see the scars. So if she had a nipple created, it would be symmetrical to the opposite side. And again, she'd look like she's had a breast lift. The 2 stages corresponds to having a tissue expander placed first, going through expansion, and then having that implant exchanged for a final breast implant at a separate stage. Bilateral nipple-sparing mastectomy patient with 2-stage submuscular implant-based breast reconstruction. Similarly, tissue expander, the patient went through expansion and then had her implant exchanged for a final breast implant. Mastectomy reconstruction using both tissue and implants. That's commonly with the latissimus dorsi myocutaneous flap. Here's an example of a patient who's had bilateral mastectomy. She has had a latissimus dorsi myocutaneous flap on the right side and standard two-stage breast reconstruction with a tissue expander and a final implant on the left side. You can see that the right side does have a bit more shape, maybe slightly more natural appearance because of the tissue, and that's one of the benefits of using tissue. Another example, a one-sided mastectomy with a delayed right latissimus dorsi myocutaneous flap and two-stage implant-based breast reconstruction. Mastectomy reconstruction using a person's own tissues, the most common site to harvest the tissues from the abdomen, and that's commonly with what's called a perforator flap, where all the muscle and the coverings of the muscles are maintained in place. We just take the skin and the fat to create the breast. Here's an example of a person who had a left-sided skin-sparing mastectomy. She underwent radiation. You can see the radiation outline on her left chest in the preoperative photograph, and then a flap creating her left breast, and then a symmetry right breast lift to match. You can see her abdominal scar. That is easily hidden using underwear. These are photograph underwear. They're quite different than standard undergarments. This is a person who underwent a right skin-sparing mastectomy, immediate perforator flap from the abdomen, and this person had nipple reconstruction with what is called a 3D nipple tattoo. She did not require any revisions, so she had her flap and then nipple reconstruction. Her skin paddle is quite small, not very visible, but it's a circular skin paddle right in the center where her nipple once was. This patient had a bilateral skin-sparing mastectomy. The SRM stands for a skin-reducing mastectomy pattern. Looks like a breast reduction, and immediate perforator flap from the abdomen. She later went to have nipple reconstruction just using the skin from her abdomen, which is I'm marking with the arrow, to use for her nipple reconstruction. This patient had a right-sided nipple-sparing mastectomy and immediate free flap or perforator flap from her abdomen to create the breast. Finally, aesthetic flap closures. This is for patients who are not interested in breast reconstruction or desire revision of their mastectomy. And this encompasses many different techniques. I've created this slide just to show the variations of scar patterns that patients actually get to help select. There are many different incision patterns. They really are based upon what the patient's goals are. And these are patients that have had aesthetic flap closures. And this image was actually taken from not putting on a shirt, which is part of the Go Flat movement that started in 2016 and has continued, where more and more women are choosing not to go through breast reconstruction and are choosing various forms of flat closures. In summary, there are many reconstructive breast surgery options for patients who go through lumpectomy, mastectomy, and it really is a combination or an amalgamation of oncologic breast surgery, aesthetic surgery, and complex reconstruction that does create reconstructive breast surgery. My goal, and I think the majority of people who do these types of procedures, we have the goal of advancing reconstructive breast surgery with innovative operative techniques, state-of-the-art technology, and very importantly, interdisciplinary collaboration. So thank you for having me as part of the panel.
Thank you, Dr. Pestana. You're a welcome member of our team. And now our next speaker will be Dr. Yosef Zaiden, our radiation oncologist, and his topic will be advances in breast cancer radiation. Thank you, Dr. Zaiden.
Great. Well, thank you for having me. Great pleasure to be part of today's panel. I'll be covering radiation therapy. So usually when we see patients in radiation therapy before getting started, they have already completed the surgery part, the systemic therapy part, and then they come and see us for consultation for radiation therapy. And the very common question that we usually get is, do I need radiation therapy? The answer is that radiation therapy remains to be the standard of care in most women after having breast conserving surgery or lumpectomy. The graphs shown here are shown from a meta-analysis with more than 10,000 patients across 17 randomized clinical trials where patients were randomized to breast conserving surgery alone or breast conserving surgery plus having radiation therapy. You could see on the top graph on the right side that adding radiation therapy reduces the chances of recurrence after lumpectomy from 31% down to 15% at 10 years. And in the long term, at 15 years, this results in a reduction of breast cancer mortality from 20% down to 17%. So we have this rule of thumb: for every 4 prevented local recurrences, we could save 1 life from mortality from breast cancer. Now, fortunately, radiation therapy improved tremendously over the past 4 decades. So back in the 1980s and the 1990s, we were doing traditionally the 6 weeks breast radiation therapy, or the 30 session schedule. This is, of course, very time consuming. Even the equipment that we were using back then were more crude. It caused more toxicity. Now, with the advances of research and technology in the early 2000s, we started abbreviating the course of radiation therapy more down to 3 weeks. And then in 2012, we introduced the partial breast radiation therapy, where we focus the radiation beam on only the lumpectomy cavity with the margin, as shown here on the right side, comparing whole breast versus partial breast radiation therapy. And then in 2020, and during the pandemic, everybody was more in a rush to finish radiation therapy faster. We introduced the 1-week whole breast radiation therapy, or the fast forward schedule that we're still learning more and more about. Of course, none of this would have been possible without research and advances in radiation technologies. So how do we use technology to protect normal tissues? As you can see here on the CT scan on the right side, this patient is getting ready to get radiation therapy to the left breast after having left breast lumpectomy. Now, you could see a common challenge is that the heart is very close to the target. And of course, we want to protect the heart and the lungs while delivering radiation therapy to the target. So one way to deal with that is to use a technique called the breath hold technique, where the patient holds the breath for a few seconds. And this gives us a very precious distance between the heart and the targeted breast, where we could deliver the radiation therapy safely. And we and others have studied this. We could reduce, using these techniques, the mean heart dose by 50%. Another technique that we commonly use is the prone breast technique. And this is essentially requires the patient to be able to lay down, face down. The table board has a hole in the middle where the breast can separate nicely by the action of the gravity from the chest wall. And then we could safely target the breast without putting excessive radiation dose through the heart or the lungs. Now, some women come to us and they require a more sophisticated type of radiation therapy that targets the nodal basins or the draining lymphatics of the breast. Those are typically patients that have node-positive disease, where the breast cancer has metastasized from the breast to the regional lymph nodes, typically the axillary lymph nodes. So as shown on the diagram on the far left, the draining lymphatics that need to be covered for those patients include the axillary lymphatics, the supraclavicular lymphatics, and the internal memory chain. And for that, we have a very nice platform called the RadExact platform, where we could shape the radiation dose very nicely to target all these nodal stations in addition to the breast, while putting minimal dose through the heart and the underlying lung. So at the Lynn Cancer Institute, we are always at the forefront of technology for breast cancer. And we are really excited to have an additional armamentarium into our tools that we use. And this is proton therapy. Just last month, we had the beaming ceremony, where the last beam was taken by the crane into the building, the structure that is sitting now in what used to be the parking lot of the Lynn Cancer. This is how it's going to look like when the project is finalized, and we are anticipating to treat the first patient in 2026. This is really a very exciting technology, and the reason for that is shown in this diagram shown below. As you could see, the hard the hard line here for photon therapy, you see that the dose is deposited at a certain depth, but then the dose started to gradually fall off with depth. Whereas with proton therapy, after the dose is deposited at depth, there is this sharp dose fall off, allowing us to really target the radiation where it needs to be. This is so-called Bragg peak, which is a property of proton therapy that distinguishes them from photon therapy. So how we can use this in some of our breast cancer patients, I'll give a couple of examples here. So for example, this patient is a patient who had mastectomy and reconstruction. This is a tissue expander in place. You could see with photon therapy, anatomy is really difficult, and the radiation therapy goes through segments of the heart and the lung. Whereas with the proton therapy, you could see the dose cloud hitting the target structures, the chest wall, and in this case, the internal memory chain, really nicely, where the dose is nicely carving away from the heart and lung. So it really will allow us to avoid in certain patients giving excessive doses to the heart and the lungs. And people have studied that. For example, in this article, there has been a reported drop in the mean heart dose from 1.9 gray with photon therapy down to 0.3 gray with proton therapy, which is really impressive. Also, there's been a reported drop in the lung mean dose from 17.5 gray down to 11 gray with proton therapy. So, and again, every single gray matters here. So we're really excited to have this technology for the right patient. Now, another challenging situation that is called the so-called leptomeningeal metastasis or dissemination. These are patients that unfortunately develop dissemination of the disease into the cerebrospinal fluid within the brain and the spine. And for that, we usually employ a technique called the craniospinal irradiation. This is really a very time-consuming, very labor-intensive treatment. But you could see on the diagram on the right side how with photon therapy, even with the best attempt that we have, there is still spillage of the dose into anterior structures like the heart and the lung, shown here in blue, and the bowel down low, in order to target the area at risk within the brain and the spine. Whereas with proton therapy, we'll be able to nicely carve out the dose where it matters around the brain and the spine. And you could see the dose almost stopping at the anterior edge of the vertebral body, which is a major advantage with minimal to no dose at all going anteriorly. And people have studied that preliminary from Memorial Sloan Kettering in this report that compared proton therapy to photon therapy for leptomeningeal dissemination of breast and lung cancer patients in this report. And they showed actually a survival benefit, although this needs to be studied more because the numbers are really low, but the results are really exciting. So in summary, radiation therapy in 2024 made major progress over the past few decades. We have reached a stage where radiation therapy is really personalized and there is no one size that fits all. And that's why this panel spends every week about 2 hours or more discussing all the cases that run through the tumor board. And that is really important. And this multidisciplinary discussion is always results in better outcomes for our patients. Overall, radiation therapy has improved schedules today and is less time consuming than it used to be with better accuracy. Almost half of my patients today can finish radiation therapy within a week, and the other half 3 weeks to 4 weeks. So, and this is a major advance compared to the classical 5 to 6 weeks radiation. We have employed new techniques and platforms that reduce toxicity. And we are really excited to add proton therapy to the available platforms of breast cancer therapy at the Lynn Cancer Institute for select patients. Hopefully that is coming up in 2026. And I'll thank you for your attention.
Thank you, Dr. Zaiden.
Okay,
And our next speaker will be Dr. Angelina Tay. a medical oncologist, and her topic will be new medical oncology treatments that are on the horizon for our breast cancer patients. Thank you, Dr. Tay, and thank you, Dr. Zaiden.
The topic of my discussion today is going to be medical oncology treatments on the horizon for breast cancer. There are so many new exciting treatments currently under investigation, but for the sake of time, I thought I would just narrow my talk to three subjects that have gotten a lot of attention over the past year. The first one is ribociclib for high-risk early-stage breast cancer. The second topic will be the concept of treating ultra-low HER2-positive breast cancer. And then the third topic will be targeting hibernating cancer cells. So ribociclib is one of three drugs that we currently have that fall into this class of drugs known as cyclin-dependent kinase or CDK4/6 inhibitors. These are medications that essentially work by disrupting the cell cycle, preventing cancer cells from replicating. And in 2016 and 2017, the FDA approved the three CDK4/6 inhibitors that we have today, palbociclib, abemaciclib, and ribociclib. And all of these drugs were initially approved in the metastatic setting based on their successful results in the initial trials. One of these CDK4/6 inhibitors, ribociclib, appears to be emerging as possibly one of the most effective CDK4/6 inhibitors in combination with an aromatase inhibitor. Follow-up studies are now showing that this can improve overall survival. So investigators then asked, well, what happens when you move these treatments out of the metastatic stage and into earlier stage disease, and how would that impact outcomes? So for further background information, there was a trial called the Monarchy trial, which used 2 years of abemaciclib combined with endocrine therapy, which was taken for 5 to 10 years, and looked at how patients did. Again, this was in the high-risk breast cancer population. So that meant that these patients had larger tumors, node-positive disease, higher grade disease. And in terms of risk of cancer recurrence and risk of metastases, the combination was proven to be more effective for those who took the combination versus those who did not. Then investigators decided to try asking a similar question for ribociclib, which I mentioned earlier may be emerging as one of the more effective CDK4/6 inhibitors. So the Natalie trial, which was published earlier this year in the New England Journal of Medicine, was another phase 3 trial looking at the safety and efficacy of ribociclib. Now, unlike the Monarchy trial, the ribociclib was given for 3 years, not 2 years, and it was combined with an aromatase inhibitor for patients with stage 2 or 3 disease. Unlike in the metastatic setting, this trial used a lower dose of ribociclib, 400 milligrams instead of 600 milligrams. The curves in terms of risk of breast cancer recurrence are very close, but at 3 years, you can see some separation of approximately 3 months lower risk of breast cancer recurrence, leading to the approval of ribociclib in combination with endocrine therapy for high-risk early-stage breast cancer last month. So now this is an option available for patients with stage 2 or higher risk breast cancer. The pros and cons should be discussed with your oncologist, if you are a candidate. The next topic I wanted to review was the ultra-low HER2-positive breast cancer group. So many of you know that HER2-positive breast cancers tend to behave more aggressively than HER2-negative breast cancers. In 2018, the American Society of Clinical Oncology and the College of American Pathologists set forth specific guidelines on how to differentiate between a HER2-positive and a HER2-negative breast cancer. In the pathology department, there's a special technique called immunohistochemistry, also referred to as IHC, which involves using a special chemical dye used to that's basically applied to the tissue that's removed from the patient's breast, usually from a breast biopsy, and it determines the intensity of staining of HER2. So if you have an IHC score of 0 or 1+, it means that you have HER2 negative disease. And this means that there is either no staining or incomplete membrane staining that is very faint or barely perceptible. HER2 positive disease is patients who have IHC 3+ disease, meaning that there is complete circumferential membrane staining that's very intense. And then there's this equivocal category, which is 2+ IHC, which is weak to moderate complete membrane staining in over 10% of invasive tumor cells. If you have an equivocal result, the next step is to do a special test called the fluorescence in situ hybridization test, which looks at the levels of HER2 gene expression. And so if you are what they call FISH, fluorescence in situ hybridization gene amplified with the HER2 2+ result, then it falls into the HER2 positive category along with IHC 3+. We know that about 15 to 20% of all metastatic breast cancer, based on this classification, is HER2 positive. But what's interesting is that an additional approximately 60% of what would normally be classified as HER2 negative metastatic breast cancers are actually what we call HER2 low, where they have some membrane staining, either IHC 1+ or IHC 2+, but FISH non-amplified. So investigators asked, well, we know that HER2-directed treatments are very effective in treating metastatic breast cancer. How about the group of low HER2 expressors? So in 2022, investigators published this DESTINY-Breast04 study, which looked at patients with HER2 low expression, those who had unresectable disease or metastatic disease who had gotten 1 to 2 prior lines of therapy, and randomized them to a drug called T-DXd, which stands for trastuzumab deruxtecan. This is a very special drug that is what we call an antibody-drug conjugate, which delivers chemotherapy in a very targeted way to HER2-expressing cells. So it randomized patients to either that drug or TPC, treatment of physician's choice, which typically comprised of a non-targeted form of chemotherapy. And what it demonstrated was that there was a significantly prolonged progression-free and overall survival among previously treated patients with HER2-low metastatic breast cancer. And the difference was the median overall survival difference was approximately 6 months. So pushing the envelope further, the question was, well, what about this ultra-low category, which is defined by HER2 0 by IHC, but with some faint membrane staining? So then the DESTINY-Breast06 study was designed looking at this very low expressing HER2 group of patients and randomized them in a similar way as the DESTINY-Breast04 study. The main difference was that in the Breast06 study, patients did not have to have prior chemotherapy. So these were chemotherapy naive. So patients were randomized to T-DXd or treatment of physician's choice. And at 12 months of follow-up, the mean disease-free, progression-free survival difference was approximately 5 months. So based on these results, we're really starting to see a shift in the paradigm of how we see HER2-positive breast cancer. Historically, HER2-positive breast cancers comprise maybe 15 to 20% of the population of breast cancer patients, but now we know that even patients with HER2 low and ultra-low expression do respond to treatment. 2 months ago, the FDA granted breakthrough therapy designation for T-DXd for the treatment of patients with unresectable or metastatic hormone receptor positive HER2 low or ultra low breast cancer. By breakthrough by breakthrough therapy designation, it just means that the FDA is acknowledging that we have therapy that may be superior than clinically available treatments for patients with ultra low HER2 disease. And hopefully the process of approval of this drug for that category of patients can be expedited. So that is something that I think we'll be hearing a lot about in the future. The last topic I just wanted to spend time on is targeting hibernating cancer cells. So as many of you know, patients with estrogen receptor positive breast cancer receive endocrine therapy after surgery with the intent of targeting clinically undetectable micrometastatic deposits, hopefully eradicating those deposits and optimizing the chance for cure. But unfortunately, we know patients may relapse even decades after surgery through mechanisms likely involving something called tumor dormancy. Tumor dormancy is this concept that there is this long quiescent state in which tumor cells are present but not observable, meaning that they are not detectable radiologically or by blood testing. The challenges of treating hibernating cancer cells is that these are cells that are usually slowly proliferating or in a state of halted growth. Chemotherapy often doesn't work against cells like this because chemotherapy works best against cells that are rapidly proliferating. In the same vein, hormone therapy may not be effective as this relies on active cell division. So one of the areas of intense research now is on what's called epigenetic regulation. This gets a little bit technical, but basically it's the idea that certain carbon and hydrogen groups, what we call methylation, can influence the way certain genes, such as tumor suppressor genes or oncogenes, are activated or suppressed. One particular drug or one particular target that has been researched is this G9A enzyme, which is known to methylate a certain protein called histone H3, which results in repression of tumor suppression genes. And in preclinical models, targeted inhibition of G9A have reduced cancer recurrence and improved outcomes. So I think this is the tip of the iceberg. I think we'll be hearing a lot about research in this area of hibernating tumor cells and targeting those cells in order to continue efforts to optimize chance of cure in patients. So stay tuned, and just wanted to thank our patients who entrust their lives to us and our colleagues. And I just wanted to give a special shout out as well to Dr. Diane Carlson, who gave me some of her HER2 positive slides for this talk. So thank you.
Thank you, Dr. Tay. Very great information. And our next speaker will be Dr. Teresa DeCesar, also a medical oncologist. And her topic is going to be updates on chemo regimens and immunotherapies. Dr. DeCesar.
Hello, everyone. This is Teresa DeCesar. I'm a medical oncologist at Lynn Cancer Institute. I basically will be following up in part of Dr. Tay's speech with advances in breast cancer therapies. Okay, so how do I advance here now? Next. Okay. So simply, breast cancer stages are stage 0. When this is a non-invasive breast cancer that still needs to be removed, followed by radiation. Sometimes we will give something called prophylactic anti-estrogen therapy, but we're not worried at stage 0 that there's a risk for metastatic disease. A stage 1 breast cancer is a breast cancer that is less than 2 centimeters. Stage 2, you either have positive lymph nodes or a breast tumor that is 2 to 5 centimeters. And then stage 3 is 5 centimeters and larger or multiple lymph nodes. And stage 4 is any size of breast cancer in the breast and lymph nodes, but it has spread beyond that. So already went through that. To the next one. So definitions, I'll be discussing a few things such as neoadjuvant therapy, adjuvant therapy, and treatment for metastatic disease. Neoadjuvant therapy is when we give treatment before surgery to shrink the tumor. Adjuvant therapy is treatment that's given after surgery, and metastatic treatment is given when cancer is spread beyond the breast and lymph nodes, and that is one of our only options. So one of the recent advances is in triple negative breast cancer. So what we're seeing now is that if you have a triple negative breast cancer that's 2 centimeters or greater or positive lymph nodes, is we start treatment in the neoadjuvant setting. And this treatment is actually given under a Keynote 522, which means we are incorporating immunotherapy. Immunotherapy, such as Keytruda, binds to these receptors, and what it does is it helps restore T-cell response and an immune response from your body to help fight off this cancer. So let's say this is a breast cancer, this is a T-cell, which has now been activated to fight off the breast cancer. And these are these PDL receptors that these new immunotherapies actually work upon. And this is Keytruda. So you have Keytruda that's binding to these receptors here, and it cannot actually activate. This is just the same thing. So a background, before we had Keynote 522, pembrolizumab monotherapy was showed some efficacy in patients with metastatic triple negative breast cancer with some manageable toxicities. Anti-tumor activity was observed in treatment-naive and previously treated patients. Pembrolizumab, which is also Keytruda, plus standard chemotherapy in the neoadjuvant setting, which is again before surgical resection, improves PCR rates, which is pathological complete response. So we treat somebody with neoadjuvant chemotherapy, they go to surgery. Once they go to surgery, there is 0 cancer cells left. Now, in the metastatic setting, when we give pembrolizumab, we're looking for PDL1 CPS scores of greater than 10, which means that cancer cell has to have some PDL1 in it. And that's the standard. And if you can see, there is a 9.7 month versus 5.6 month progression-free survival. In the neoadjuvant setting, however, you do not need to have PDL1 positivity. And even so, we don't even check on that. The second therapy I'd like to discuss are PARP inhibitors. Now, this is given in the adjuvant setting. That's after you have chemotherapy, after you have surgery, or in the metastatic setting. And these 2 PARP inhibitors are olaparib and talazoparib. You really need to be BRCA positive to be able to take these 2 drugs. And they selectively target this homologous recombinant repair deficient cells. This is just, I'm not going to worry about this, but what happens is in the Olympia trial, olaparib showed in metastatic breast cancer patients that were HER2 negative a median progression-free survival of 7 months when we treated with olaparib versus 4.2 months when they were given chemotherapy of physician's choice. The Embraca trial also showed benefit from 8.6 to 5.6 months, and this is progression-free survival. Olympiad extended follow-up showed no prior chemotherapy for metastatic breast cancer. And this is the olaparib, and this is chemotherapy of patient's choice. And still, beyond the 12 months for metastatic breast cancer, we're still seeing 24.6% of patients who are not progressing versus 12, which are on the chemotherapy arm. So the median overall survival went from 14.7 with chemotherapy to 22.6 with olaparib, which is a pill. This is basically giving us the same information. But there are some adverse events. Most of them we are able to mitigate through giving some other medications. And nausea appears to be one of the biggest. Fatigue is quite significant, but 12% had actually a grade 2, and only greater than grade 3 was this 2%. You can see some anemia, which is manageable. And as you see in the others, most are grade 1, which will make this drug pretty good for patients to tolerate. And both of these drugs are FDA approved for patients with metastatic and germline BRCA mutations. The conclusion was now adjuvant olaparib, this is after surgery, improves overall survival at 3.5 years median follow-up, and it did have a significant threshold for overall survival in the second planned interim analysis. So it's a great tool that we have. Now, future directions for PARP inhibitors, benefits another group, perhaps PALB2, other DNA repair genes, or HRD identified tumors, or germline BRCA negative associated with HER2. These are still questions that need to be answered. Okay. Now, antibody drug conjugates are some of the best drugs that we do have available today, and these are HER2 and chemotherapy drugs that are put together. So I'm going to try and show you how these mechanisms work. So number one is you have an antibody. Number two, you have something called a linker. And number three, the red, is the payload. So here you have, for example, a targeted agent like it binds to this tropo2. And then you have these red areas that are chemotherapy. Well, these are brought into the cell itself, and that's how they work. So how this works is you have number one, binding to the antigen. So just like some patients have ER-positive breast cancers, these are tropo2. It's internalized into the breast cancer cell. It degrades, and the chemotherapy is in the cell. And then some of the chemotherapy is released, and some cells that are surrounding this one chemo cell is actually working on the cell that exists outside of the cell that incorporated this molecule. Now, these are HER2-directed monoclonal antibodies. Here you have the cleavage linker. Here you have the chemotherapy portion, and this portion is the HER2 antibody. So, sacituzumab govitecan was the first-in-class tropo2 ADC. It's now the preferred treatment for patients with metastatic triple-negative breast cancer. There's also ongoing studies evaluating this in hormone receptor positive breast cancers in combination with targeted therapies and immunotherapies. I must note that sacituzumab govitecan is also given in patients at many times who are ER positive and they have failed all anti ER therapies because now they're just resistant. Dato-DXd is another Tropo2 that has demonstrated impressive clinical activity in pretreated metastatic breast cancer. And there are also other multiple targeted therapies, which we can hopefully use. So, in going back to the triple negative breast cancer, this is sacituzumab. This is a patient who has, here's the patient's liver, multiple darker areas in the liver. And this is all breast cancer that has metastasized to the liver. After 8 cycles of sacituzumab, if you look at the liver, there has been significant improvement in the burden of breast cancer cells. Significant. So, and we do see these dramatic responses. So, in summary, targeting Trop2 in breast cancer makes sense because expression of Trop2 is high in most breast cancers and is higher than in normal tissues. Sacituzumab govitecan is the first ADC therapy approved for metastatic triple-negative breast cancer. It improves progression-free survival and overall survival. Newer therapies on the horizon. So, next paragraph, I'm sorry. Next. Okay. All right. This is going through unapproved here. So let's do anti-HER2 drugs. Old at this time are trastuzumab, which is Herceptin, pertuzumab, and ado-trastuzumab emensine, which we call this TDM1. New drugs is Enhertu and tucatinib. Evolving treatments for metastatic HER2-positive breast cancer is Enhertu was granted FDA approval for HER2-low breast cancer on August 5th, 2022. Dr. Tay did discuss the Destiny trial, but the mechanism of action again is you have a HER2 antibody binds. These smaller areas in red are the chemotherapy portion. Again, brought into the cell, degraded. Some of the chemotherapy goes outside of the cell, and neighboring tumor cells are also killed by this technology. Same picture. And progression-free survival, if we use Enhertu versus TDM1. And these charts are just really amazing how we see progression-free survival. And tucatinib is actually an oral pill. And what we mostly use this for is in patients with previously treated HER2-positive metastatic breast cancer with brain metastasis. And I have one patient who has had HER2-positive breast cancer now for 16, 17 years, has been on almost everything. She has had brain mets. She's now on tucatinib with capecitabine and Herceptin. And thus far, over the past year and a half, she has not had any further recurrences in the brain. But this is CNS progression-free survival, which means central nervous system, brain metastasis at 1 year. This is the tucatinib, trastuzumab, and CAPE. And this is tucatinib, trastuzumab, and CAPE. And if you can see here, 34% progression free CNS disease compared to 7.9. So this is an excellent drug for brain lesions. And tucatinib is a tyrosine kinase inhibitor, which is a small pill, and it works against selective HER2 therapies. Again, progression-free survival in total at 1 year 29 versus 14. At 6 months, 57 versus 38. And these are heavily pretreated patients. Sorry. Okay. So again, HER2 low breast cancer. I think Dr. Tate quite touched on this, so I'm not going to give much of a talk. However, we are now incorporating HER2 positive HER2 therapies for patients who were unable to receive these in the past because they didn't have 3+ staining by IHC or FISH positive for HER2+. In summary, new generation, paradigm shift to current system of HER2 classifications. We do need some better biomarker and assays to define the subgroup to optimize patient selection. Other agents also in testing for HER2 low breast cancer, and more to come in the following years. Vaccines. There are some vaccines out there if necessary. However, at this time, with all this new era, I think that we are doing a great job in helping breast cancer patients. Thank you so much.
Thank you, Dr. DeCesar, and thank you to all our physicians. We're so fortunate to have a multimodality team here at the Lynn Cancer Institute. We're grateful to everyone that has joined us today. And we have, as always, these lectures are recorded. So if you do want to go back over anything, you can contact Lee when she sends you the evaluation, and she will send you the link to this lecture. It'll probably be available next week. And Dr. Morell is on. Did you see the question, Dr. Morell?
I only saw the one.
Okay, we have one. It's, does the body recognize, I'll say this wrong, xenoestrogens? And in parentheses, she said environmental estrogens. It's XENO estrogens.
Yeah, if anyone wants to comment on that, I'm not familiar with that terminology. I think that I'm really, the speakers did such a great job, and there was so much clarity, I think, given to understanding the hormone positive breast cancer and the relationship to where estrogens are produced and so forth. But this is not a minor question. It's not an A to B. What we measure when we're measuring estrogen receptors on the cells is just the best that we have, but it doesn't mean that every breast cell that's even estrogen receptor negative has no impact by hormones. So we're just really cautious about supplementing hormones in any way, shape, or form. But we know people have different risks associated with doing that and different quality of life issues. And so those can be individualized. And I think what I'm really proud of my colleagues for and for this presentation is you actually not only get a sense of all the different areas where so much advancement is happening, but also that we are not shy from the science that's going behind all of the decision making, and that the folks that are here and working on this are continuously curious and continuously evaluating the new concepts, the new findings that we have, the new breakthroughs that we have, and that you see how these studies require very detailed, long-term, sometimes follow-up, quality studies that's looking at all of the factors that affect outcome. And that's what we do all day long and with all the meetings that we attend. And so I'm just really proud of the quality of the reviews that occurred today, because it shows you how much breakthroughs are happening. It also tells you how much complexity there is to all of this, and that everybody's more than willing to individually go through your specific situation or your specific considerations for prevention, for diagnosis, for testing, for all of it. So thank you. And thank you, Jan, for organizing as usual.
Yeah, thank you, Dr. Morell, and thank you to all the physicians. We can only appreciate how much time and energy goes into the research to put these slides together, and to ask each of you to condense it into a 10-minute presentation. I know is not the easiest thing to do. So, but everybody did a fantastic job, and we're all better off for it. So thank you so much. And thank you to everyone who joined us today. I do want to do a quick notice that on Saturday of this week, October 19th, from 9:30 to 12:30, we're going to extend our breast cancer education here at the Lynn Cancer Institute. It will be an event that will also provide shopping. We have 30 amazing vendors that are coming for shopping. We have 8 clinicians coming that will provide education on various areas of breast cancer. We are going to be providing skin cancer screenings complimentary, and we have 4 breakout speakers that are going to be coming to educate us. So it's a day of health, wellness, and shopping. So we hope you can join us. And on October 30th, in our nutrition series, our oncology dietitian, Brandy Hyatt, will be providing a presentation on nutrition and breast cancer. Thank you to everyone. This was amazing education. Thank you, Dr. Morell, for all your support. And everyone have a great rest of the day.
Thank you.
Bye-bye, and thank you.